This recording will continue to talk about diagnostic assessment for CAD and MIs, but it will also talk about the problems for the patient with acute coronary syndrome and how we respond to those problems, specifically managing acute pain. When infarction occurs, one of two ECG changes is usually observed: ST elevation MI or a STEMI, or non-ST elevation MI or a non-STEMI. An abnormal Q wave wider than 0.04 seconds, or more than a third the height of the QRS complex, may develop depending on the amount of myocardium that has necrosed. Women having an MI often present with a non-STEMI. After the acute stages of an unstable angina episode, the healthcare provider often requests an exercise tolerance test, also known as a stress test, on a treadmill to assess for ECG changes consistent with ischemia, evaluate medical therapy, and identify those who might benefit from invasive therapy. If the patient cannot tolerate the exercise test, instead of being on a treadmill, medication will be used. Pharmacologic stress test agents such as dobutamine may be used instead of the treadmill. Cardiac catheterization may be performed to determine the extent and exact location of coronary artery obstruction. It allows the cardiologist and cardiac surgeon to identify patients who might benefit from percutaneous coronary interventions or from coronary artery bypass grafting. The patient with coronary artery disease may have either stable angina or acute coronary syndrome. If acute coronary syndrome is suspected or cannot be completely ruled out, the patient is admitted to a telemetry unit for continuous monitoring or to a critical care unit if hemodynamically unstable. The priority collaborative problems for most patients with acute coronary syndrome include acute pain due to the imbalance between myocardial oxygen supply and demand, decreased myocardial tissue perfusion due to interruption of arterial blood flow, decreased functional ability due to fatigue caused by the imbalance of oxygen supply and demand, decreased ability to cope due to the effects of acute illness and major changes in lifestyle, potential for dysrhythmias due to ischemia and ventricular irritability, and also potential for heart failure due to left ventricular dysfunction. Astute assessment skills, timely analysis of troponin, and analysis of the 12-lead ECG or 18-lead ECG are essential to ensure appropriate patient care management. This is particularly important since the average time a patient waits before seeking treatment is over 2 hours. This delay lessens the 4 to 6 hour window of opportunity for the most advantageous treatment with percutaneous intervention. First, we're going to talk about managing acute pain. Patients with diabetes mellitus and coronary artery disease may not experience chest pain or pressure because of diabetic neuropathy. In this population, the onset of acute coronary syndrome may be signaled by new onset AFib. Evaluate any report of pain, obtain vital signs, ensure an IV access, and notify the healthcare provider of the patient's condition. Pain relief helps increase the oxygen supply and decrease the myocardial oxygen demand. So the cause of pain with an MI is that the heart tissue isn't receiving the oxygenated blood that it needs. So it's the ischemia that's causing the pain with an MI. So by opening up those vessels or finding ways to provide more oxygenated blood to the tissue, and also by making the tissue demand less of it, then the patient can experience a relief of that chest pain. So again, pain relief helps increase the oxygen supply and decrease myocardial oxygen demand. The American Heart Association recommends several pain management strategies, including nitroglycerin, morphine sulfate, and oxygen. A lot of times in terms of pain management for MI, you'll hear about MONA, M-O-N-A. M stands for morphine sulfate, O stands for oxygen, N stands for nitroglycerin, and A stands for aspirin. At home or in the hospital, the patient may take nitroglycerin to relieve episodic anginal pain. Aspirin 325 milligrams, an antiplatelet drug, may also be taken daily to prevent clots that further block coronary arteries. Nitroglycerin, also sometimes just referred to as nitro, is a nitrate that increases collateral blood flow, redistributes blood flow towards the subendocardium, and dilates coronary arteries. In addition, it decreases myocardial oxygen demand by peripheral vasodilation, which decreases both preload and afterload. So nitroglycerin works by decreasing myocardial oxygen demand, decreasing preload and afterload, and dilating those coronary arteries so that more oxygen-rich blood can go into the tissue. With nitro, the patient can take up to 3 doses in 5-minute increments. So if I take a dose of nitro and wait 5 minutes, I'm still having pain, I can take a second dose, right? I can do that up to 3 times, and at that point, if I'm not at the emergency room, I need to be there if I don't have pain relief after 3 doses. Angina usually responds to nitroglycerin. When ischemia persists, the healthcare provider may prescribe IV nitroglycerin for management of chest pain. Begin the drug infusion slowly, checking BP and pain level every 3 to 5 minutes. Please be sure to review all charts in yellow nursing safety priority boxes on your own while studying. During administration of long-term oral or topical nitrates, an 8 to 12-hour nitrate-free period should be maintained to prevent tolerance. So if I'm using a topical form of nitro, I'd want to remove that at night, right, so that I don't develop tolerance. The healthcare provider may prescribe morphine sulfate to relieve discomfort that is unresponsive to nitro. Morphine promotes comfort, decreases myocardial oxygen demand, relaxes smooth muscle, and reduces circulating catecholamines. If hypoxemia is present, the healthcare provider may prescribe oxygen at a flow rate of 2 to 4 liters per minute to maintain an arterial oxygen saturation of 90% or greater. Placing the patient in a semi-Fowler's position often enhances comfort and tissue oxygenation. A quiet, calm environment and explanations of interventions often reduce anxiety and help relieve chest pain. Primary outcome is that the patient will have increased myocardial perfusion, as evidenced by an adequate cardiac output, normal sinus rhythm, and vital signs within normal limits. Because MI is a dynamic process, restoring perfusion to the injured area, usually within 4 to 6 hours for a non-STEMI and 60 to 90 minutes for a STEMI, often limits the amount of extension and improves left ventricular function. So those time frames are important to know. So we want perfusion restored in a non-STEMI in 4 to 6 hours, and for the STEMI, the ST elevation MI, between 60 to 90 minutes. And why are those time frames there? Because if the tissue goes longer than that, then it's more likely that there's going to be necrosis or cell death. So the quicker we can open up any occlusion and reperfuse that cardiac tissue, the more likely it is that the patient isn't going to have long-term deficits because of damage to the heart due to lack of oxygen and lack of blood flow. Aspirin therapy is recommended. It inhibits both platelet aggregation and vasoconstriction, thereby decreasing the likelihood of thrombosis. If the patient has new onset angina at home, teach him or her to chew 325 milligrams or 4 baby aspirins that are 81 milligrams each immediately and call 911. The antiplatelet effect of aspirin begins within 1 hour of use and continues for several days. If in the hospital setting, aspirin should be given on arrival to the emergency department or when an MI occurs in the hospital. Glycoprotein inhibitors such as abciximab may be administered IV to prevent fibrinogen from attaching to activated platelets at the site of a thrombus. When giving glycoprotein inhibitors, assess the patient closely for bleeding or hypersensitivity reactions. If either occur, notify the healthcare provider or rapid response team immediately. Monitor the platelet level 4 hours after starting the drug and daily thereafter. Notify the cardiologist if the patient experiences a significant decrease in platelet count per agency protocol. Dual antiplatelet therapy is suggested for all patients with acute coronary syndrome. Incorporating aspirin and other drugs such as clopidogrel may be used. The major side effect for each of these agents is bleeding, so observe for bleeding tendencies such as nosebleeds or blood in the stool. Medications will need to be discontinued if evidence of bleeding occurs. Teach patients the signs of bleeding and when to contact the healthcare provider. Antiplatelets such as clopidogrel work by preventing platelets from aggregating together to form clots. In addition to antiplatelet therapy, anticoagulation therapy may be used to prevent clot formation. Choice of anticoagulant is determined by provider preference. Anticoagulation is stopped before cardiac catheterization and is usually not continued following coronary intervention unless a high risk for clot reformation exists following the intervention. Once-a-day beta-blocking agents, sometimes called beta blockers, decrease the size of the infarct, the occurrence of ventricular dysrhythmias, and mortality rates in patients with MI. The provider usually prescribes a cardioselective beta blocking agent within the first 1 to 2 hours after an MI if the patient is hemodynamically stable. Beta blockers slow the heart rate and decrease the force of cardiac contraction. Thus, the agents prolong the period of diastole and increase myocardial perfusion while reducing the force of myocardial contraction. And you should recognize the drugs that end in LOL as your beta blockers. During beta blocking therapy, monitor for bradycardia, hypotension, decreased level of consciousness, and chest discomfort. Assess lungs for crackles indicating heart failure and wheezes indicative of bronchospasm. Hypoglycemia, depression, nightmares, and forgetfulness are also problems with beta blockade, especially in older patients. Unless contraindicated, all patients experiencing non-STEMI or STEMI should be discharged on beta blocker therapy. Do not give beta blockers if the pulse is below 55 or the systolic BP is below 100 without first checking with the healthcare provider. The beta blocking agent may lead to persistent bradycardia and further reduction of systolic BP, leading to poor peripheral and coronary perfusion. Healthcare providers frequently prescribe angiotensin-converting enzyme inhibitors or ACE inhibitors or angiotensin receptor blocker or ARBs. You can recognize your ACE inhibitors because of that pril ending PRIL. Lisinopril is your prototype ACE inhibitor, and you can recognize ARBs because they end in sartan. ACE inhibitors and ARBs are usually prescribed within 48 hours of acute coronary syndrome if the ejection fraction is equal to or less than 40%, and those with hypertension, diabetes, or stable chronic kidney disease to prevent ventricular remodeling and the development of heart failure. Both ACE inhibitors and ARBs increase survival rate after an MI. Monitor the patient for decreased urine output, hypotension, and cough. Check for changes in serum potassium, creatinine, and blood urea nitrogen or BUN. For patients with angina, the healthcare provider may prescribe calcium channel blockers to promote vasodilation and myocardial perfusion. Statin therapy reduces the risk of developing recurrent MI, mortality, and stroke. Thrombolytic therapy using fibrinolytics dissolves thrombi, so these are clot busters, in the coronary arteries and restores myocardial blood flow. Your prototype is alteplase, and you'll frequently hear TPA being used in the clinical setting. Thrombolytic therapy is given in a unit where the patient can be monitored continuously. It is indicated for chest pain of longer than 30 minutes duration that is unrelieved by nitroglycerin, with indications of STEMI by the ECG. It is not indicated for a non-STEMI. The Joint Commission requires that fibrinolytic therapy begin within 30 minutes of ED arrival. After clot lysis with thrombolytics, there's increased risk for vessel reocclusion. To maintain patency of the coronary artery after thrombolytic therapy, providers usually prescribe aspirin or IV heparin. For some patients experiencing acute coronary syndrome, primary percutaneous coronary intervention may be used to reopen the clotted coronary artery and restore perfusion.